My name is Tatiana Avanesova. I'm vitreoretinal surgeon and vitreoretinal surgeon of Department of Ophthalmology, Central Clinical Hospital in Moscow. I'm assistant of Ophthalmology Department of Voronezh State University, Medical University, and it's my pleasure to introduce our great team of speakers, Professor Ahmed Magdy Bedda, Alexandria University, Faculty of Medicine, Head of Department of Ophthalmology, Egypt, Alexandria. Dr. Mohammed Samir, Vitreoretinal Consultant, Alexandria University, Egypt. It's my pleasure to introduce Gracia Pertile, Head of the Ophthalmology Department of Sacro Cuore Hospital, Negrar, Verona, Italy. Peter Stalmans, Professor of Ophthalmology, Head of Ophthalmology Department of the University Hospital Leuven, Belgium. And Zoran Tomic, Vitreoretinal Surgeon, Miller's Clinic, Belgrade, Serbia, and Department of Ophthalmology in Uppsala, Sweden, Uppsala Hospital, University Hospital. And me and Dr. Samir will moderate this meeting. And we can start, I think. Thank you very much. My presentation is about clinical case of suprachoroidal haemorrhage. The 74-year-old old man presented with the history of acute vision loss in his left eye while sudden tilting the body. Interesting, he saw the flash and blurry vision 1 hour prior to this episode. He had hypertension, he had low myopia from childhood, and he suffered glaucoma, both eyes, during 20 years. And his past history, ocular history, included cataract extraction with implantation and explantation and reimplantation IOL 3 times. Last implantation with IOL Sputnik and tangential keratotomies was 10 years ago. And also he had express valve implantation in 2010 and glaucoma filtrating surgery 2 years ago. Here is the slit lamp examination. What we see the lens, it calls Sputnik, like satellite. It was inverted by Fedorov and Zakharov in 1964, and it has the haptic elements that fixed its iris claw lens that fixed the lens in the back, and these elements fixed in the front. Here's the express valve. The visual acuity was light perception, faint light perception, and the IOP was normal. And we see choroidal detachment when we make slit examination without any fundus examination. We can see it. And ultrasound confirmed it. We can see kissing choroidals. And we decided to operate him. And here is the surgery. First of all, we made scleral trepanation, posterior scleral window, and to avoid the replacement of the lens, I insert saline into the vitreous cavity just behind the lens, and I could not insert infusion line. I do it simultaneously, controlling IOP. When the blood flow decreased significantly, I insert the light fiber through the paracentesis and saw a total retinal detachment. So I previously had the plan to make a scleral window in 2 or 3 quadrants, and now at this moment I decided to switch from extraocular to intraocular surgery. So to make sure the trochars are in the correct position, in the correct position, I do it carefully with the fundus control. After that, the infusion line was inserted, and we started routine surgery of retinal detachment with PFCL injection and putting chandelier light. We found the break at 7 o'clock, and there was no signs of choroidal detachment, so we made air fluid exchange, laser, and finished the operation with silicone tamponade. To avoid pupillary block, I made iridectomy. And after that, we had this picture. The visual acuity is better, it's hand moving, but we had the problem with IOP, uncontrolled IOP of 40 millimeters on maximally tolerated medical therapy. The retina was attached, so we made the decision to remove the silicone oil. And we can see the retina is attached. We can see many streaks, choroidal streaks. And we finished with air tamponade. Here is the picture fundus and OCT, 2 months follow-up. Everything is okay. He has total excavation of optic nerve, and he, due to his poor vision, he could not fix his gaze to make OCT well. So, and IOP stabilized. So, but he is happy, and he could see something. And it's a reminder for all of us about risk factors for suprachoroidal hemorrhage, and among all of them, we can we don't forget about Valsalva maneuver. I think he had this maneuver as a factor of suprachoroidal hemorrhage. Thank you for your attention.
Okay, I would like to ask Tatiana, what's the proper timing for interference in these cases?
It was just 3 days after his coming in our clinic.
So you leave the patient for 3 days before intervention. What about giving the patient more time to be sure that this blood will liquefy and be like this?
Yeah, if we don't have kissing choroidals, we can do this time. We can have this time, but the choroidals where the detachment was so high, so we decided not to risk with IOP and compression of the optic nerve.
Professor Stalmans is asking about why you didn't use an AC maintainer.
Why I'm going?
Why you didn't use an AC maintainer? AC maintainer. Anterior chamber infusion. at the beginning of the surgery.
Just
Yeah.
not to replace this IOL because it it's a pupil iris claw lens. It could be
Yeah.
shift to the cavity.
Yeah. That's right.
My
It may be
yeah, I inject the saline just after behind the lens.
yes. That's very nice.
So, good evening, everyone. Thank you very much, Tatiana, for the kind invitation to participate in this meeting with the distinguished panelists. And my presentation is about a rare type of retinal detachment. It's schisis detachment. And so the term retinal schisis include senile retinal schisis or degenerative retinal schisis, juvenile or excellent schisis, and secondary retinal schisis occurring secondary contraction, intraretinal hemorrhage, exudation, and cystic degeneration. Yes. Degenerative retinal schisis has been found in 7% of studied populations older than 40 years of age. Clinically detectable outer layer breaks have been found in between 11 and 24% of cases, and in less than 10% of these cases, retinal detachment can occur from fluid passing from the schisis cavity to the subretinal space. I will start first by the degenerative retinal schisis. Two types of retinal detachment occur in relation to degenerative retinal schisis. The first one is the localized non-progressive retinal detachment. In this condition, the retinal detachment is confined to the area of retinal schisis. The second is the progressive symptomatic retinal detachment. And in both conditions, all patients with retinal detachment should have an outer layer break that provides communication between the schisis cavity and the subretinal space. Yes? The localized non-progressive retinal detachment remains confined to the area of the schisis and is stable. And the risk of this localized retinal detachment to transform to the symptomatic progressive retinal detachment is actually very rare. Yes. The progressive symptomatic type of retinal detachment, as its name denotes, extends beyond the area of the retinal schisis. However, significant posterior extension is rare. It occurs in 3.2% of cases when followed up for 9 years. So this progressive type is rare, and the extension posterior is rare, and reaching the macula is very rare. The lifetime risk of development of progressive symptomatic retinal detachment complicating retinal schisis in patients with retinal schisis may be as low as 0.5% of those cases. The X-linked juvenile retinal schisis, as everybody knows, is characterized by a central macular schisis and peripheral schisis. The pedigree analysis indicates that the incidence of retinal detachment, the other slide, Muhammad, the previous slides, Muhammad, please. Previous slide, yes, more? Yes. Retinal detachment occurrence in this X-linked juvenile retinal schisis is a rare event. However, the presence of a peripheral schisis with the central schisis is in about 50% of cases. Yes. Now I'll give you an example of each of these types. This is a patient who presented to me with this central retinal detachment. When you look to the inferior part of this photograph, you find something which looks like a retinal cyst. When we go more peripheral, you will find this is not a retinal cyst. This is something as if there is an outer layer break, edges of which are rolled upon each other. There is fenestrated outer wall, and you can see the retinal pigment epithelial at the bottom. Yes, Muhammad? Yes, more Muhammad? Yes. And this is the appearance of the patient. The question now is what to do for these patients. This is the progressive symptomatic retinal detachment, which is actually a very rare condition. And honestly speaking, this is the only case I have met throughout my 30 years of practice of retina. There is always an outer layer break. It has a smooth rounded margin, maybe rolled posterior edge, and extension of the schisis into the macula, as I told you before, is very rare. And this is one of the very rare types. What to do for this case? I decided to fix this retinal detachment by, this is the appearance before we start the surgery. Then we proceeded as usual with induction of posterior vitreous detachment by active suction. Then following removal of vitreous, we injected petrocarbon liquid to flatten both the schisis cavity and to push the subretinal fluid to the periphery. Then we went to the periphery, removing the vitreous in the periphery. We did not find inner retinal holes. This large outer retinal break is the cause of the retinal detachment. So we made a drainage vitrectomy at a site which make it accessible to remove the subretinal fluid and the fluid of the schisis cavity. Then endolaser was applied and gas tamponade has been done. Yes. This is the appearance before surgery, and this is 5 days after surgery. 5 days, the gas is filling probably 60% of the size of the globe, and the laser marks are seen here infratemporally at the site of the retinotomy. Yes. This is the appearance 5 days after surgery, and this is 2 weeks after surgery. The retina is totally flat and attached. Yes. And this is 4 weeks after surgery. You can see the laser marks at the retinotomy site. The outer layer break is seen in this photograph. Yes. This one. And when we followed this patient for after a long period of time, this is 2 weeks after surgery, yes, Mohammed, and then 6 months after surgery, the condition remains perfectly fine. The retina is attached, the schisis cavity is collapsed. So this is the first example about the progressive symptomatic retinal detachment complicating retinal schisis. The second example is this one. This is a patient which presented with metamorphopsia. The OCT demonstrated this epimacular membrane distorting the macular area. Yes. So, yes, go more. And when we started to examine the periphery of the retina, we find this retinal detachment in the upper and temporal part of the fundus. And there is a large outer layer break is seen here with rolled edges. This is not a full thickness retinal break. This is a break in the outer layer of the schisis cavity. As we mentioned before, this type of retinal detachment remains usually confined to the area of the schisis. So this is by itself is not an indication for surgery. The indication for surgery here was removal of the epimacular membrane. We also made the same thing, retinotomy in the periphery. We drained the fluid of the schisis cavity and in the subretinal space from this side. And we applied laser treatment actually to the retinotomy site and to the outer layer break. And we added a row of laser as a delimiting laser to this area, which is detached. Yes, yes, Muhammad. So this is the appearance of the patient before surgery with the epimacular membrane, and this is the appearance 3 months after surgery. The epimacular membrane has been removed, the schisis cavity collapsed, and the retina was attached. Yes, Muhammad. And this is the OCT before, and this is after surgery. Yes, Muhammad. Now, the third example about X-linked juvenile retinal schisis, which is also a very rare condition to find retinal detachment complicating this schisis cavity. This is the left eye of the patient having X-linked juvenile retinal schisis and a schisis cavity in the periphery. And this is the right eye of the patient who developed retinal detachment, complicating a similar schisis cavity with large inner layer holes. Yes, Muhammad. So when we examined the fundus of the patient, this was the appearance. It was a long-standing issue with the subretinal band and the nasal aspect, and this was the full picture of the patient. On examination, I've found an outer layer break, which is at the equator. So I decided to use a scleral bucket to fix this detached retina. And the right side, wait, Muhammad, return back, please. So on the left side, this is the detached area before the scleral buckle. On the right side, you can find after doing a scleral buckle, the retina in the upper half is attached. However, still some fluid in the inferior part of the retina. Yes, Muhammad. And when we followed up the patient, this was the appearance immediately after scleral buckling procedure. Yes, go ahead. Yes, and this is 1 month after surgery, and this is the appearance. There is the large inner retinal breaks, and there is a retinal bridge between these large holes, which is exerting traction, preventing proper reattachment of the inferior part of the fundus. Yes, Muhammad? Yes. So return back, please, Muhammad. This is when we decided. The video is not, no, Muhammad, the video is not working. Yes. Did the video work? So we decided, so the video did, Yes, yes. So we decided to go and excise this retinal bridge, and we decided to excise the whole inner layer of the schisis cavity. You know that this area of the retina, there is an absolute stoma corresponding to this schisis cavity, so it does not compromise the vision of the patient. We removed this part. So this is the part which was exerting traction on the inferior part of the macular area. Yes, Muhammad? And this is the appearance. Go ahead, Muhammad. This is the appearance before the vitrectomy surgery, and this is after the surgery. You can notice this, the traction now has been released. Go ahead, Muhammad. And so this is the scenario before surgery. This is after the scleral buckle, and this is after vitrectomy. You know, the condition of down and to the right side, it looks as if the retina is totally attached. Yes, yes, Muhammad. And when we compare the left eye, which has schisis without retinal detachment, now this right eye, which has been operated by both scleral buckle and vitrectomy to release the traction, the condition is almost the same between both eyes. Yes, Muhammad. Yes, Muhammad. So in conclusion, for these three types of retinal detachment, cases of retinal schisis without detachment don't require treatment. However, treatment can be used in exceptional cases to limit progression of the posterior edge. You don't, on routine basis, you don't need to do any treatment, yes? Retinal detachment in eyes with retinal schisis may be caused by breaks in other locations than the schisis area. In these cases should be managed like ordinary cases of retinal detachment. Breaks may occur in the inner layer, outer layer, or in both layers of the schisis cavity. Yes. Breaks are more common in the outer layer of degenerative retinal schisis and the inner layer of juvenile retinal schisis. Yes. A break in the outer layer is essential for development of retinal detachment. Yes. Localized non-progressive retinal detachment requires only follow-up. Surgery is indicated if there is another indication like an epimacular membrane, in our case we presented. Eyes presenting with progressive symptomatic retinal detachment complicating retinal schisis are candidates for rapid surgical intervention. The surgery, yes, the surgery should entail vitrectomy, identification of outer retinal holes, endodrainage, gas tamponade, yes. Cases of retinal schisis having outer layer breaks at or anterior to the equator can be treated with the scleral buckle. Vitrectomy can be combined with the buckle if there is residual traction. Thank you very much.
Could I ask you about second case with the secondary epiretinal membrane? What do you think about Sockland buckling prophylactically in this case?
So this is a patient having an epimacular membrane, and this was the indication for surgery. So if this patient does not have an epimacular membrane, in my hands, there is no indication for intervention at all. However, as I told you, the risk of progress of this type is very rare. So this does require prophylactic scleral buckling. If you would like to do something to give the patient a chance to prevent progression, you can do delimiting laser to the edges of this detached retina. However, if you don't do anything, the condition will go fine without surgery.
Yeah, I mean, if we make surgery, macular surgery, there is some risk to increase the proliferation, vitreous proliferation at the periphery. I mean, peeling, macular peeling with buckling.
Yeah. In this condition, if you would like to do buckle, you have to treat the outer layer break and put a buckle. However, to my mind, I don't think that it's of great value in these conditions.
Thank you. Thank you very much.
I would like to ask Professor Magdy, is there a role for ILM peeling in these cases while doing vitrectomy?
I think all recent studies have demonstrated that epimacular membrane peeling with ILM peeling or without does not make a lot of difference. So you can remove it. It can be, the ILM can be removed with the epimacular membrane by itself. However, these days I don't go for eyelid peeling in cases of macular puckers like this.
Yes.
And Professor, what do you think about retinotomy for the cases with X-linked retinoschisis?
So, eventually, we have removed the inner table. However, I don't believe that we have complete retinotomy, removal of all layers of the retina will not add a lot to the success of the surgery in this condition.
Yeah, okay, buckling is the first, and after that, vitrectomy.
Yes, removal of only the inner table, which is exerting traction. And in this case, specifically, buckling worked because the outer layer break was anterior, was at the equator.
Thank you so much. Yeah, it's really challenging cases. And Ahmed?
Thank you, Professor. Thank you, Professor, very much for that interesting and rare case. And it's my honor now to present Professor Stalman. He's going to talk about a case of trauma after the 2016 terrorism attack, and our condolences for that attack for sure. Please, Professor.
Yeah, please.
Yes, this is just a short video showing how we're working now in our new operating theater. We're doing all the surgeries with the Artivo in 3D nowadays. You see here the EVA device standing on the side of the surgical tray. And I'm looking aside of the microscope towards a 3D screen, a large screen, and all the other personnel is also watching the video. And in the same field of view, you can see the EVA screen. So this is just to show you how nowadays we are doing surgery. The case I will show you is a young woman who was in the Brussels airport attack now already 4 years ago. You remember these images, how the Brussels airport was bombed. And you will see now x-rays of her feet and her legs. There's all shrapnel of iron inside all of her body. It was really an awful case of trauma in this bombing. This was an ultrasound done very shortly after the trauma, and this was done a few days later. You see the retina is completely detached, and we see a closed funnel. This is an outside image taken. There's even some rust on the external eye, and here you see the retina interiorly into the eye and some naked sclera. It was, of course, a very bad situation, but we tried to restore it anyway. So here you see an anterior chamber infusion cannula introduced into the eye, and I'm introducing my instrument cannulas very horizontally, not to enter under the choroid in the choroidal area. Here I'm using the TDC cutter of the EVA to dissect away all vitreous that I could find. And here I'm stretching the funnel. And this is a little trick I would like to show you. I'm using not PFCL, but viscoelastic to open this funnel. This is actually visco that I'm using, and this stretches the retina, allowing me with an end gripping forceps to remove scars which have formed on top of the retina, and slowly progressing, injecting more visco, I'm starting to open this funnel. Now I am using the cutter to dissect the peripheral retina. Otherwise it was impossible, of course, to flatten this retina. And in the end, now I'm using heavy liquid. Oh yes, this is some more scarring which is present under the retina. There's a stalk formed, and I'm removing the scar tissue from beneath the retina around the optic disc, again to allow the retina to flatten and to reposition it where it should be. There's of course not too much retina left, but it was nevertheless possible to stretch it open, and by heavy liquid and the necessary amount of patience to reposition it. Again, I'm using both vitrectome and end gripping forceps to remove any scar tissue on top and beneath the retina, and now I'm using heavy liquid and it opens. Of course, there's some holes being formed, but the macular area is now flattened. And when this was achieved, I'm doing a direct perfluorocarbon to silicone oil exchange. I'm using a twin light chandelier for that. And at the end of the surgery, the part of the retina that was still left in the eye was attached. Now I'm using a Tano brush. It's a diamond dusted brush to wipe open the edges of the retina to remove any curling of the retina. This is some peripheral flap which I'm cutting away with the vitrectomy. We're pretty close to the end of the surgery now, again using the diamond dusted Tano brush to trying to flatten the retina as good as possible and to remove any folds that are left. The surgery, of course, took a few hours, which I'm showing you now in a 3-minute video. This is the end of the surgery. And this was the day after the surgery, or a few days after the surgery. She has hand movements, and 1 year later, this is the image 1 year later, it's still completely attached and she still has her hand movements, and this is 3 years later. So it remains pretty stable. Of course, this is an eye that I would first decide not to do surgery on, but since it was a special circumstance, I tried to go to do the surgery anyway, and I ended up with an eye with still hand movements after 3 years. So you never know what to expect, and I think every eye deserves at least one chance trying to repair it.
I just want to ask you 3 questions. The first one, what visual acuity do you interfere in these cases? To what extent of minimum visual acuity can you interfere in cases of trauma? And the other question, when to interfere, after how many days from the primary trauma date? And the third question, do you do ILM peeling or buckles in cases of trauma?
Okay. First question is, what visual acuity do you base yourself on in order to do a surgery? Well, yeah. I don't, because if you have an eye with a completely attached retina and an extensive vitreal hemorrhage, the patient will have light perception. But if you remove the blood, he can still have even reading acuity. So I would not base myself too much on the reading or on the visual acuity, and even not too much on the ultrasound. I think the only way to figure out if the retina is still treatable is to go in and have a look. And I've done many times surgery where I entered into the eye and had a look, and I decided after 10 minutes it's a lost cause. But then I think it's the only circumstance where you can really be sure towards the patient that there's no hope anymore. So my opinion is that in such cases you should always give it a try. The second question was the waiting time, and I think that's a very, very good question. That's the key question here. On one hand, you don't want to do the surgery too soon, because in that case you can have new hemorrhages. On the other hand, you cannot wait too long, because then you will have too much scar formation. So I usually wait between 7 and 10 days before doing such trauma surgery, except of course if we see that there's, for example, an endophthalmitis, we may do it sooner.
That's right, that's right. Do you use bucket in trauma cases, or do you routinely do ILM?
No. Buckling I only do when there's redetachments, then I use a buckle. And ILM peeling, when I see on my, I have an intraoperative OCT in my microscope, so I can scan the retina during the surgery. And when I see a membrane, a scar, I will of course remove it, but not as a routine in order to prevent scar formation.
Okay.
Professor Stalmans, have you done any reconstruction of anterior chamber?
In this case, there was no iris left at all, and since her vision is only hand movements, and she is a lady with dark skin and dark eyes on the other side, it's not an aesthetical problem in her case that she has a dark pupil. So for the moment, I did not decide to do that.
How do you protect the cornea from silicone oil contact?
Well, usually there's a thin layer of anterior chamber being formed in front of the silicone oil. This is 5,000 centistokes silicone oil, which has a high viscosity, so it usually contracts somewhat into the posterior chamber, and with some luck, it's not touching the cornea. So for the moment, the cornea is keeping up well.
Yeah, thank you so much. And our next speaker is Zoran Tomic, also trauma case. And just a moment.
I'll start it now. This is a case of scleral perforation, and with due to assault and with the glass. And we did the anterior part of the surgery first, and it was unaffected. But when we entered the posterior segment, the retina was completely cut with the glass, and it was fixed. So we decided to do the relaxing retinotomy in the periphery. My idea was first to do 270 degrees of retinotomy in order to prevent dislocation of the macula. And you will see soon that I tried to inject the perfluorocarbon, but it went behind the retina. You will see it soon. I hope that video is running. Can you see it? It stopped for me.
It's running, yes.
Is it running?
Yeah.
No, I don't see it. Okay. After this trial, I will try to comment without, yes. I did the removal, the completing of retinotomy 360 degrees, and then I did the removal of subretinal membranes, which was the cause of contraction of the retina. And then I proceeded with the bimanual relocation of the macula, because this was my experience from macular translocation surgery, which helped me in this case to solve the problem. So I did the relocation, and I injected the perfluorocarbon using a bimanual technique with the flute silicone tip brush needle, and then in the other hand perfluorocarbon double-barreled needle. So this was a case of a 21 years old female, and her initial visual acuity was light perception. And at the end of surgery, you will see here that there was some folding of the retina in the periphery that I unfolded with the silicone brush cannula. And then the final visual acuity was 0.1. She underwent one more surgery with the removal of reproliferation at the retinotomy edges. And then after that, we did removal of silicone oil 3 months after, and the final visual acuity was 0.1. You will see the flattening of the retina by adding of some perfluorocarbon and manipulating and massage of the retina with the silicone tip brush needle. And then we injected, of course, at the end, we did the, after laser, fixing the retina with laser, we did the fluid air silicone oil exchange. And you will see those laser scars. And then this complicated case, together with all other challenge cases, are printed in a book that I wrote together with my fellow Dr. Spandau from Uppsala and a colleague from Spain, Dr. Diego Ruiz Casas from Madrid, and 12 other surgeons. And the book is published by Springer 1 year ago. I can refer to this book. And the historical part was written by my teacher, Dr. Živojinović. And that's all. Thank you.
Thank you so much. It's interesting, challenging case. Zoran, could you tell us the tips and tricks how to be sure of the right position when you translocate the retina and macula?
You would have to deal with, you have to have the concept in your head, where is the 6, 3, and 9 and 12 o'clock, and then you just go after that. That was the left eye, and then I just rotated the macula in the towards 3 o'clock.
Thank you. Professor Stalmans?
Yes, Zoran, I have a very nice case, by the way. I wrote down a few questions. I've sometimes heard that it's not wise, or it's wiser not to do a 360-degree retinectomy, but to leave at least some part of the peripheral retina attached to avoid it from rotating. Do you agree with that?
Yes, I agree. And if you just listen to my presentation, I told that I wanted to do 270, and I injected the peripheral carbon, but retina was fixed. Then I had to complete it because in the upper nasal part there were subretinal strands, which didn't allow me to attach the retina. That's the reason I did 360, and as a consequence of that, I got the dislocation of macula.
Yes. Another question. I use for myself when I'm doing a vitrectomy 2 different vitrectomy modes. I use a core vitrectomy mode to remove vitreous quite quickly, and a second step for me is the shaving to remove the vitreous close to the retina. What setting would you use when you do a retinectomy?
When I do the retinectomy, I take 150 cuts per minute. And then when I do the anterior retinectomy, then the shaving modes.
I see. And one last question. This is something my colleague from Rotterdam suggested me. In a case as you're doing, you are expecting that PVR will develop. You could opt not to use laser, but to simply fill the eye with silicone oil. And if PVR forms, the retina will contract somewhat and will slip into its new place under the oil. While if you have applied peripheral laser, you stapled the retina in the periphery, fixed, and it will, because of that, lift itself again. So the theory is that in such cases where you expect PVR to be formed, not to use laser primarily, but to let the retina slip and settle itself, and do the laser at the time of the oil removal. Is this, you think, a good idea?
I don't know. That is my fear of the slippage of the retina. In this case, actually had the reproliferation at the retinotomy edges, but I was able to remove it, and after that it was all right.
Okay.
Okay, Dr. Samir, do you have a question?
Yeah, I would like to ask Dr. Zoran, do you do direct PFC silicone exchange routinely?
No, I go over the air. The only thing, if I do the giant tears or 360 retinotomy, then I go directly to silicone oil because of the risk of the slippage.
Yeah.
Okay, Professor Magdy Bedda.
Yeah.
You should unmute, please.
Yes, I would like to ask Dr. Stalmans about the idea of leaving the retina without doing laser in such cases of giant retinal tear. If you leave the retina without doing laser, you will 100% in these cases find the retina detached immediately after the surgery. Isn't it? Or I'm wrong with this, Dr. Stalmans? What's the idea of leaving the retina without laser treatment? In these conditions, you will definitely find the retina slipped and the silicone oil can pass under the retina. So do you agree on leaving the retina in these cases without laser for fear of proliferations?
Yes, I've done it a few times, and it actually works quite well, because if you staple the periphery of the retina on the location at the end of your surgery and the retina contracts, it will not be able to slip down, and because of that, it will detach again. If you do not apply the laser, you allow it to slip somewhat, And usually I find it having a better outcome and fewer surgeries to let it slip and, for example, take out the silicone like 2 months later and apply the laser at that time and end, for example, with the gas tamponade.
Okay.
May I add something?
Yeah,
of course.
go ahead, please.
Yes, I think in this discussion I would add my experience that if I do the giant tear repair in the far periphery, then I would, this is my experience, then you get just a bigger slippage. If you do the central, if the giant tear or central retinotomy is like in some cases of trauma, then you can leave it without laser. Because the pump, the RP pump is stronger in the center than in periphery. I think that would be my choice to do in the periphery, not in the, if behind the equator.
Okay. Does anyone else has any question for Dr. Zoran?
I think it makes sense what Zoran said, that you can leave it without laser posterior to the equator, because in this case, because of the anatomy of the eye, because when you have the retinotomy posterior to the equator, it can only slip behind and touch tangentially, and so it makes sense what you said. When I have a very peripheral retinotomy, I don't dare to leave it without laser.
Me too. In this case, it was quite peripheral retina, and I was very close to aura, and that's the reason I did the laser. I feel safer like this.
Yeah, I agree.
Okay, let's move to Professor Gracia. She's going to talk about amniotic membrane graft application in vitreoretinal surgery. Dr. Gracia, please.
Thank you very much for the kind invitation. And I want to show you the use of amniotic membrane in cases of large retinal breaks. Like posterior colobomas, retinal colobomas, or one case of toxoplasma staphyloma, or myopic eyes. So the first case I'm going to show you is a case of charge syndrome. As you probably know, it is a quite rare syndrome, a combination of different problems, but it is characterized concerning the eye by a very large chorioretinal staphyloma. These are kids with an attached vitreous, so the first difficult step is to detach the vitreous. Pardon? Can you hear me? Is there a problem?
Yes, we can hear you. Could I ask all participants to mute the mics and switch off your videos, please?
Okay.
Just a moment. We will continue here.
Pause the presentation. Okay. So we see here in this condition I stain. The video is not proceeding. Okay, so there is a lot of work to detach the vitreous up to the periphery, but the interesting part is the preparation of the amniotic membrane. It comes in a sheet from the eye bank, and then I usually stain it with blue, what you usually use for ILM staining, because it is much easier to see it. And then you can insert it. In this case, as I need a quite large sheet, I introduced it through a 20G sclerotomy. But if you have a macular hole or a smaller hole, you can just use a 27G forceps through a 23 trocars. And you see here it is useful when it is stained, blue stains, because you can see what you do. And then you see it is positioned under the first break, and then there is a second break, and then you release first with traction, and then you put it underneath the second break to complete, really to close the hole. And then in this case, PFO is injecting, and the case is completed in this way. In this way, you can fill up these large breaks in atrophic retina. Another case is this trauma case. It is a young man with a scar, a central scar in the macular area. And you see what quite often happens when from the scar tissue, you have contraction to the peripheral retina, and it causes detachment of the rest of the retina. So if you can fill up the gap here where the retina is missing, you can probably prevent destruction and keep the retina attached. So you see in this case, the scar tissue from the first operation is removed, the PVR is removed, and then finally you can, there is some work here, and all this scar tissue that cause traction toward the sclerocorneal scar is removed, and then the amniotic, a large sheet of amniotic membrane is introduced and positioned underneath the retina. You see, and then you can trim it depending on the, because sometimes you have multiple breaks, and then you can fill completely all the breaks and all the gap. And this is the postoperative result. You see that all this area where the retina was missing is nicely covered by the amniotic membrane, no traction, and the retina is nicely attached. This is another detail. You see really a quiet scar. So it seems that if you fill up the gap, then you can obtain a quiet condition and prevent reproliferation. This is another case of with a staphyloma due to toxoplasmosis, only eye of a patient, and you see in the same way an amniotic membrane is positioned, and you see here the amniotic membrane filling nicely the gap. The retina, in fact, is too short to fill completely up the gap, but this elongation of the retina permitted by the amniotic membrane can permit the complete reattachment of the retina. And this is the postoperative condition. And you see there is some traction from the amniotic membrane, so it is quite important to take a larger sheet in comparison with the break you want to fill, but you can obtain a nice result. Let's see if I can progress. And in a similar way, you can also use the amniotic membrane in high myopic eyes. Here you see the a PVR case, and the supraretinal membranes are removed, large supraretinal membranes, but there are a couple of posterior breaks, and then the two breaks are filled up with amniotic membrane, and the same technique is used. And I will show you the comparison close 1 week after the operation. You see two nice pieces of amniotic membrane positioned there, but you can notice after 2 months they are smaller. There is some contraction of this amniotic membrane, especially this one. So it is really important to have a large sheet that covers all the edges of a break. Otherwise, you run the risk that the contraction make cause a reopening, let me say, of the retinal break. So we have learned using it. We have learned some lessons, and other lessons are to be learned, of course, because it is just the beginning of the use of this technique. So you can fill up large retinal defects even when the retina is rigid, but it tends to contract, so it should be quite large. And in some cases, when the retina, like in chorioretinal colobomas, and the retina is thin and rigid, you should release the traction, put a large patch. Maybe it might be useful to use a sandwich technique. Let me say one sheet underneath the retina and one on top of it to prevent the contraction and the reopening of the hole. Thank you very much.
Thank you so much, Gracia. It's very interesting cases and very interesting technique. Could I ask you, are these cases with long-term silicone tamponade?
No, usually the silicone oil is removed. We use silicone oil because they are quite complex cases, but we usually remove it after 2 months, 2 or 3 months, depending. In cases of PVR, I usually leave silicone oil also for 4 months. It depends a little bit on the condition, but in all the cases, it was possible to remove silicone oil.
Thank you. Do you use laser?
Not at the edge of the break. I do laser if necessary at the sclerotomy site, at the retinotomy, but not at the area where I put the membrane, because I'm not sure the membrane can benefit from laser. I have even the impression that it will contract even more than without laser.
Thank you. We have the question, comments from Professor Magdy Bedda. Please.
Yes. Dr. Pertile, thank you very much for this nice illustration. However, I'd like to ask 2 questions. The first one is how to make sure that you put the epithelial side up and the corneal side towards the retinal surface.
Yeah, it's very useful to stain it, because when you stain it with blue, we can recognize the epithelial side.
However,
it's very hard to recognize it.
However, do you feel that the staining covers the epithelial side only? Sometimes I notice it covers both sides.
No, usually I have the impression that it stains the epithelial side, and you can recognize it, as the membrane is quite thick, so you can see the layer that is stained. You should make sure not to use too much dye, because sometimes if the dye slips when you are staining it, it slips underneath the membrane. Yeah, you remember it's that you stain both sides, but you don't know anymore what is what.
And the second question is, have you noticed a difference in the results between putting the amniotic membrane graft under the retina or above the retinal surface?
To be honest, up to now I used it underneath the retina, but I know from some other colleagues that they used to put it on top of it, even in macular hole. To be honest, I have no experience on this topic, but I'm going to try it on top of it.
Okay.
Do you have any experience with this?
No.
No.
Thank you very much.
Thank you.
Dr. Samir?
I think Professor Stalmans has a question. Could you ask first, please?
Yes, Gracia, thank you. This is a very interesting, intriguing technique. I have 0 experience, but I wonder, I can imagine when you install the flap under the retina, that the sides of the retina keep it in place. But if you will use the flap on top of the retina, I just wonder what force will be generated to make sure the flap stays there when you remove, for example, the silicone oil. Because there's, I don't think there's any scar formation between the retina and the amniotic flap. So I just wonder what mechanism is there to keep it in place.
Now, probably, I guess, as I said, I have no experience either. I heard Peter Zurman tell about a large sheet of membrane on top of a macular hole. I can guess that after some time you get a kind of a scar tissue between the RPE and the amniotic membrane, and so as the hole is filled, the retina break is filled by amniotic membrane. If the remaining RPE is working, it can keep the retina in place. But as I said, I have no experience on this topic, so it might be that it goes away anyway. I don't know. This was my first reason to use it underneath the retina to prevent slippage and it from moving away. I will tell you when I try it. Unless you tried before me, then I hear from you.
Well, that's a promise. And a second question, I've never manipulated amniotic membrane in an eye, so I don't know how it feels, but I've had many headaches by manipulating eye lamp flaps. Is this more easily to manipulate in an eye than an eye lamp flap? In other words, do you think it will replace inverted eye lamp flaps to seal large macular holes?
No, I don't think so, to be honest. It is much thicker usually. Maybe in the future it would be interesting to ask the eye bank to prepare a thinner sheet of amniotic membrane, because indeed it is quite thick, and so it is difficult to get the right size underneath a macular hole. And I think that when you use ILM flap, it is much easier to fill properly the hole, not to have too large sheet of ILM. So I prefer ILM instead of amniotic membrane, and use amniotic membrane only when I cannot use ILM flap.
Okay, thank you, Gracia.
Okay, one last question, Dr. Gracia. Are you obliged to use silicone oil tamponade when you use the amniotic membrane graft, or you can use gas if the break is horizontal or the superior haemorrhage?
No, you can use gas for sure, especially if you use it in macular hole cases and you put it underneath. Probably if you put on top, it might be safer to use oil. The point is that in cases of large congenital colobomas, chorioretinal colobomas, or PVR associated with high myopic eyes, I usually use silicone oil. But indeed, you can use gas if you think that the case can be fine with gas and don't need silicone oil for other reasons except for the amniotic membrane.
Thank you very much.
Thank you.
Thank you. Now let us turn to the next speaker, Dr. Mohammed Samir. Please, I just share your presentation. Okay.
It's an honor to join this prestigious meeting, Retinal Bridges. It's a very nice idea from my colleague Tatiana, and I thank her very much for the kind invitation. I'm talking today about the modified end of lamp. As we know, the cases of myopic macular hole. In highly myopic eyes, the axial elongation of the eye and the development of posterior staphyloma results in thinning of the retina and choroid, which lead to myopic maculopathy. As you see, this is multiple photos of posterior staphyloma cases with MRI. So what is the mechanism of myopic macular retinal detachment? We have three factors that can be involved in the pathogenesis of this challenging type of detachment. which is the tangential traction on the macular surface by the condensed posterior cortical vitreous, the anteroposterior vitreous traction, and the reduced retinal adherence because of the atrophy of the retinal pigment epithelium and the choroid. So this case is a 46-year-old patient with macular hole retinal detachment, hand motion visual acuity, and so our decision was to use the endoblamb. Endoblamb, as we see, is a silicone blamb with titanium wires inside the body of this blamb with without endolite. This is without the modification we have done. This is the video. First of all, we put two marks for the stay sutures for the head of the blamb, as we see. Placing the endoblamb, doing adequate indentation is very important, and external drainage at this site, and we have to take our care and be cautious that it's very thin at the posterior pole in these cases. And at the end of the surgery, we put intravitreal air to adjust the intraocular pressure. So this is second day after the surgery, post-macular buckling, and it was attached completely and successfully. 5 days post-operative, we had recurrent retinal detachment due to failure of the proper localization of the blamb. And as we see here, this is the arrow here is marking the endoblamb end, which is away from the macular hole, which is the cause of failure and the cause of the unclosure of the hole and reposition of the retina back. So our modification was to do a lightened endoblamb by making a track at the end of the blamb, as we see, using a 25 gauge endolite, putting the endolite, the fiber optic endolite, at the end of the blamb. As we see, it will be lightened, and doing the surgery as usual by putting the lightened endoblamb at its place, taking stay suture and looking through the biome to the light, to the endolight. So we can locate the endoblamb and at the proper place of the macula or the fovea, so as to increase the success rate and to overcome the problem of localization or false localization, which is one of the causes of recurrence in myopic macular hole retinal detachment done with the endoblamb, as we see here. So after the surgery, first week post-operative with retina in place, and this is 1 week post-operative with the indentation of the blamb, as we see, with perifoveal subretinal fluid. 1 month post-operative with closed macular hole and retinal reattachment with post-op visual acuity of 0.2. And finally, we had published this modification, me and Professor Dr. Magdy Bedda and our colleague Dr. Ahmed Abdelhadi in Ophthalmology Journal. And thank you very much.
Thank you so much for your nice presentation, Dr. Samir, and Professor Magdy Bedda also. Thank you. Could I ask you, have you observed any protrusion of this plomb?
We didn't observe any protrusion or penetration of the plomb or erosion, if you mean inside the globe. But in certain cases, after a long time, after about 6 or 7 months, we had some migrated buccals, subconjunctival migration of the buccal, although the retina in place and the macular holes are closed.
I see Professor Stalmans wants to make a comment or question.
Yes, thank you. This is a very interesting idea to illuminate the plumb. Now, I see in the latest conferences that more and more ILM flaps are being used to seal large macular holes in myopes than using plumps. Do you think that a hole, as you have shown, could also be closed by doing vitrectomy with an ILM flap?
In our hands, we don't do vitrectomy in doing the macular buckling. We don't enter inside the eye. It's just putting the endoplumb at the proper place and making external drainage at the site. And we have compared this type of surgery with vitrectomy with gas, vitrectomy with silicone, and in our comparative studies, the macular endoplumb, the macular buckle, the illuminated buckle or the unmodified macular plumb has highest results with least complications in myopic macular hole retinal detachments.
Okay, thank you.
Thank you, Professor.
Dr. Samir, as I know, they are not produced now, this plumb.
Excuse me?
Am I right? They are not produced by...
Yes, that's right. We don't have it now, but we are working. Our team, Professor Magdy Bedda, me, and Professor Ahmed Abdelhadi, we are working to modify another new one or manufacture another new one, and we are on our way to publish as soon as possible. You are right.
Great. And have you tried to put some metal rod into the sponge?
Yes, we didn't do this because we have experience of protrusion and erosion of this metal rod through the sponge, and we used some of our colleagues used the dentist, some of the dentist rods and sponge, but we have seen many of protruded metals, so I think it's not so wise to use it. I think Professor Magdy had a comment. Please, Professor.
May I ask a question to Dr. Stalmans and Dr. Gracia Pertile about ILM peeling in those very high myopic eyes with posterior staphyloma. I would like to ask in which % of cases do you succeed in fashioning an ILM flap in those eyes with high myopia and posterior staphyloma?
Yeah, I have used it quite often, and if there was no previous ILM peeling, you can succeed, let me say, in 100% of the cases. Of course, if the ILM was already removed, then you have a problem, and you can do an ILM transplantation sometimes. You can use amniotic membrane. You can use a peripheral flap of patch of retina to fill the eye. But when the ILM was not removed in a previous surgery, then you can just stain it. Indeed, yeah, it is not so easy as in non-myopic eyes. What I like to do in cases is to use a staining under PFO. And then I just let fill between the PFO bubble and the retina some blue, and in this way you can really stain pretty well the ILM, and you can see and remove it under PFO.
Yes, I do agree with Gracia. If the patient did not have macular surgery before, it's in 99% of cases that you can create a flap. As a backup plan, I'm not such a fan of doing a retinal transplant, but I like to use the lens capsule for that purpose.
If you have it, if the patient is not pseudophakic.
Yes, and didn't have a capsulotomy, that's right, absolutely.
Yeah.
I would like to make a comment. Yes, I would like to give tips to audience it is not very easy to do the ILM peeling with flap in high myopic eyes, and there is one thing that might help in vitrectomy with this is to move the trocars, because pars plana is longer in high myopic eyes than normal eyes, and that can give you the angle that is easier to work with. And you can easily check up with the pipe light towards the pars plana and do the transillumination and position the sclerotomy behind 4 millimeters, depending on the length of the eye.
It's a good tip. Yeah.
Yeah, otherwise you can, this is a good tip, but you can also use forceps for high myopic eyes.
X large.
It's longer than normal.
Yeah, X large.
And sometimes it is useful to remove a trocar, and then you can approach, and then can you go closer with a forceps if it is not long enough.
Yes.
Exactly. The thing you described I did in Sweden, but now I have another reality in Serbia. So I don't have longer forcepses. And
Okay.
I think I adjusted to the situation, but I think the idea of moving the sclerotomy, you can move it to 5 to 6 millimeters, give you completely another angle. You don't operate from up, but from a side.
Yeah, this is a good tip for sure.
Try it.
Yeah, make a lot of sense.
Yeah, good.
Yeah.
Thank you so much. Any comments?
Yeah, I would like to add a comment, Dr. Tatiana. The problem is not with the length of the globe, as the long forceps solves this problem. The problem is with the very thin eye limb and very high myopic eyes, the poor contrast, atrophic retinal pigment epithelium. In these cases, the manipulations of the eye limb might take a long period of time, and this might end up with toxicity of phototoxicity to the retinal pigment epithelium, and it did happen with me more than once. So I'm amazed that Dr. Pertile and Dr. Stalmans talk about 99 to 100% success rate, as probably in my hands in 50% of the cases this does not work. So in these conditions, one should think of using amniotic membrane membranes. And I'd like also to ask Dr. Pertile, when you insert the amniotic membrane under of the retina, you find cases of atrophic RPE changes secondary to these manipulations. You don't induce trauma to the RPE in these cases?
I couldn't understand the last question. I start answering the first one about the light exposure and so on. I usually decrease the light intensity because quite often if you use, when you don't see very well, you tend usually to increase the light intensity or to keep the light pipe closer to the retina. But in this case, as you quite often have pale areas, retinal atrophy, you have a lot of reflection. And you see much better if you decrease with a lower light intensity than with a higher light intensity. But of course, it is important to stain it because it is almost impossible to remove the ILM properly if you don't have a proper staining. And it might be not easy to stain properly the ILM in high myopic eyes. But I think another important thing is to turn off, not off, but to decrease the light intensity. And as I said, the best staining you can get with staining under air, but even better under PFO, injecting blue between the PFO bubble and the retina. Could you repeat the second question, please? No, I cannot hear you. Turn on the microphone.
So it's on right now. Second question is about inducing trauma to the retinal pigment epithelium by trial of insertion of the amniotic membrane flaps under the edge of the retina. As I actually was confronted with this problem in a case, and in this case, actually at the end of the surgery, the ILM flap slipped away, The hole was closed. However, the retinal pigment epithelium was atrophic from the trials of insertion of this flap under the retina.
Yeah. When you use an amniotic membrane in on detached retina, you don't have any problem, any major problem, because the retina is detached. You don't need to go very close to the RPE. Might be a problem when you use it for macular hole.
Yes.
And this is why one of the reasons I'm not so happy about the use of amniotic membrane in macular holes, because you need, if you put it underneath the retina, you need to lift up the edges of the hole, and this is something that to prevent, to push it on the RPE and to traumatize the RPE. And I don't like to go underneath the retina and the edge of the hole and to lift it up. And this is why I prefer to use other things, ILM flap transplantation, of even retinal transplantation, but it's much easier because the amniotic membrane is quite stiff. And what I'm going to try when I have a good case is amniotic membrane on top of a macular hole for this very reason.
Yeah. Thank you very much.
You're welcome.
I have a question for Dr. Gracia. One of the audience is asking you how the break closed without doing laser on each periphery by using the amniotic membrane graft. What is the mechanism?
Yeah, I guess the mechanism is when the amniotic membrane stitches on the retina, you have no break, and then it can the RPE pump can function and reattach the retina. You know, it is like a buckle. When you close the hole, it reattaches. It is a kind of elongation of the original retina.
Yeah, so no need,
so
no need for laser or buckle underneath.
No. Laser might be useful, but I'm not sure, so I don't use it. I think when you close the hole, you put a sheet and you have a closed hole and a continuity between the retina and another membrane, then you get the RPE to function and to reattach the retina.
Does the amniotic membrane stick to the retina if it's above it, or you should put it only down below the retina on the RPE?
No, you don't push it underneath. When in cases of detached retina, I put the membrane underneath to cover the edges and then put PFO. And then at that time you drain and you leave it on an unattached retina, and should be enough.
Okay.
But there is no histological study or on OCT. You see, I showed a couple of pictures of the postoperative aspects, and you really see this layer of amniotic membrane very adherent to the retina. It looks like it sticks to each other. And
okay. I think we are approaching the end of our meeting. I would like to thank Tatiana very much for this very nice meeting, for this very nice work. I would like to thank my professor, Dr. Magdy Bedda, Professor Stalmans, Dr. Zoran, and Professor Gracia. And what do you have any other question, Tatiana, or comments, please?
We have no questions from audience, and as we are about to wrap it up, I would like to take this opportunity and thank our phenomenal team as well, and our public that joined us today. And this coming was made possible by the generous support of the Dark Company, and I would like to express them my gratitude also. So it's it's a pity to finish, but we have to do it. And I wish you have a good evening. Take care. Thank you for your participation. Thank you so much.
Thank you very much, Tatiana.
Bye-bye.
Very nice
you.
to meet you, and hope
Thank
to see you in blood
Yeah.
and flesh as soon as possible.
In real life, thank you so much.
Thank you. Goodbye.
Bye-bye.
Bye.